Okay, so for today's lecture, we have chapter 31, 32, and 33. Chapter 31 covers male reproductive disorders, chapter 32 covers development, and chapter 33 covers female reproductive disorders. Okay. Now, when we get into male and female reproductive disorders, just to kind of clarify this material is not that heavy duty. So next week's test, I don't want to say it's going to be a breeze, but it should be lighter for you. When we talk about male and female reproductive disorders, there's only 3 things that is usually an issue. Number 1 is usually some sort of infection. Number 2, it's maybe some sort of hormonal issue. Or number 3 is probably some sort of mechanical issue or physiological issue, well, I shouldn't say physiological, or anatomical issue where something's falling or whatever, bulging. Okay, so those are really just kind of the 3 main things, okay, that occur. So not a long drawn out pathogenesis, okay, not very difficult to understand. So if you do have, let's say, an infection, you know how do you treat an infection? You give some medication for that. If there is some sort of mechanical defect, they will do something to hold it up, okay? Or if there is some sort of hormonal issue, you would give that person medication, some sort of hormone replacement type therapy. So again, the material's not that difficult to understand, so we'll get through it. Now, for chapter 31, your PowerPoints are already tailored for you, but I did cut out some congenital disorders, and I did also cut out a big chunk of STDs. And I know you guys went over STDs and micro, so we don't need to revisit that again. And so we're going to omit, oh, she showed you all the pictures. Okay. So, yeah, we're going to omit all of this. And I do have you guys starting at this particular one, cryptorchidism. So this first congenital disorder that we're going to cover, I can never get it out, cryptorchidism. This is what is called, or what is known as hidden testes. Okay, so just what it says, hidden testes, meaning that the testes actually have not descended in their proper location. So just to go back to embryology, and we're actually going to cover a little bit of embryology in 32. But just to go over with males. Male babies, when we're talking about embryonic development, the testes actually start higher up in the pelvic cavity. And then as they continue for development, the testes will descend into the scrotal sac. Okay, and that's just normal embryological development. This situation is a congenital disorder where these babies are born where the testes have not descended into their proper location. So just please understand that this is something that these male babies are born with. They're born this way, and it's because of altered development.
Testes descend while?
Well, the testes, well, I'll put it this way. The testes do not descend into the scrotal sac where they're supposed to. So they're either going to stay higher up or maybe dislodge in different areas other than its proper location. And I'll show you pictures in a second. So, again, please understand that these children are born like this. Okay, it is a congenital disorder. They give you the incidence there. Just a few things I want to point out. This, obviously, if there is no treatment that is done, please understand, if you have the testes that are not in its scrotal sac, do you think it's going to be hard for these males to develop sperm? Yes. So understand that this will definitely cause a deficiency of spermatogenesis and leading into infertility. That is very important to know if it goes untreated. Another issue that can occur if it goes untreated is that this can really increase the chances for malignancy, and in particular testicular cancer. So this is definitely a risk factor, cryptorchidism, a risk factor for testicular cancer. And again, if it goes untreated. So these are some of the locations. Okay, so as I was explaining to you before, not only just high in the pelvic cavity, you don't have to memorize each and every section, but it can go all the way up to the abdominal, suprapubic, superficial inguinal, intracanalicular, high scrotal, even out in the femoral, okay, and perineal. So keep in mind, it's just a matter of, a better way to explain it is it's dislodged. That's how to explain it, it's more dislodged.
So we don't need to know that all.
No, you don't need to know each and every location, but just know that there is a dislodgement. Because these children can be born, you know, whichever one may occur. Okay, so they do have a particular treatment for this. Now, before I get into treatment, obviously, how would you recognize this situation? Physical examination, inspection, palpation, okay, to even understand what, you know, that this is happening. Now, when it is diagnosed, there is a particular treatment for it. They do have a surgical procedure called orchiopexy, which is where they can actually surgically remove the undescended testes and kind of reroute it. Now, I don't know all the ins and outs of the surgery, but they do have a surgery where they can pull the undescended testes down in the proper location. Now, another type of treatment that can be done, and this is used actually as an injection, is HCG. Now, what do you think HCG is actually going to do in this case?
HCG is usually for pregnancy, so
Yes.
that would help you find.
So it's used for pregnancy, which means it's going to be used to help do what? Fetal development. Okay, so keep in mind that HCG is definitely secreted and it does help for fetal development. So in this case, the, I should say, philosophy behind this is if you give the HCG injections, that is supposed to help the fetal development that did not occur. So hopefully the testes will start to fall into their proper place. So those are the two treatments. Okay. Now, the next couple of disorders that we're going to cover are acquired disorders. So this has nothing to do with being born with this particular situation. It's acquired by something else. So the first acquired disorder, and this is actually quite common, is something called a hydrocele. Hydro, water, okay? So what happens here, this is actually fluid that builds up around the testes and around the spermatic cord. So this is fluid that builds up in and around the testes and the spermatic cord. Now, this fluid does not just appear, okay, out of nowhere. There's usually some sort of situation that occurs first, and then the hydrocele is kind of like the secondary result, okay? So let's go over some of the things that can cause this type of hydrocele. First thing, scrotal injury. Okay, so that's definitely top of the list, okay, especially for this type of acquired disorder. So say, for example, a male, maybe doing some sort of martial arts, okay, gets kicked in the area, okay? So something like that can definitely cause, obviously, from injury, inflammation, fluid starting to accumulate around that area. Radiation therapy can also do that, okay, as well as infection of the epididymis. So sometimes there can be bacterial infections that can reach the epididymis, and we're going to cover that later. And that can also, from the inflammatory process, build up fluid. And testicular cancer. Testicular cancer can also give excess fluid in that area. Now, just like we talked about with cryptorchidism, we would imagine, yes, inspection and palpation. You will see most likely the scrotal sac one being larger than the other if there's a hydrocele there. What other type of diagnostic tool, or what diagnostic tool do you think would be useful to visualize this? Not an X-ray, ultrasound. Ultrasound would be better, to be a little more safer in that area, okay, to use, as well as you can visualize exactly the fluid or whatever substance that's in the scrotal sac, okay, with the ultrasound. So just know that ultrasound is probably the best choice in the diagnostic test. Now, treatment. Usually for hydroceles, they're not that complicated, okay, so usually they'll just kind of drain, okay, with the lymphatic fluids and so forth, if they're mild to moderate. However, sometimes if they are very large and excess fluid keeps accumulating for whatever reason, they can go in and drain them, but most of the times it's not that big of an issue. Okay, so that's a picture of what it looks like. So there's the fluid around the testicle, and therefore it will definitely cause more enlargement in the scrotal sac.
So, Amelia, you said if it's necessary, surgical drain, and other than that, it'll just go away on its own.
Yeah, it'll go away because once, say for example, if it's like an infection, once you have the infection under control, if that's a cause, then what'll happen is that fluid will just kind of drain within the lymphatic system. And so it'll take care of itself. But it's more like an acute type of situation for that moment. Okay, now spermatocele. Spermatocele is another one that's actually quite common, and if you look at the scrotal sac from inspection, they actually look the same, okay, because one scrotal sac is going to be larger than the other. And you can't really distinguish the two, if it's a hydrocele or a spermatocele, unless you do an ultrasound, okay. So a spermatocele is actually, believe it or not, sperm that actually collects and kind of forms like a mass or like a ball in the scrotal sac. I know it sounds strange, how does this happen? They do say that the etiology is unknown. However, they do believe that it's more of an incidence in boys that are going through puberty or pre-puberty males. So around that area, that age range. Not to say that an adult male can't get this, but more common in boys that are going through puberty. So again, this is another thing that's not that complicated. Okay, and so if it's there, small, usually it'll resolve on its own. However, if it's there a little longer and maybe causing issues, they can actually just surgically remove it. Now the next one we have here is testicular torsion. This one, the men usually cringe in the room, okay, when they see this one. The issue with this is where we have a twisting of the spermatic cord. Okay, and it actually just twists. Now, twisting of the spermatic cord, number one, let's go over what runs alongside of the spermatic cord. What runs with the spermatic cord that you remember from anatomy? Well, not the vas deferens, it actually turns into the vas deferens. Not the vas deferens, but what lies right next to it? Blood vessels, very good, and nerves. Blood vessels and nerves, which means that when the spermatic cord twists, it's also twisting the blood supply to the testes. So this is, please understand, an emergency situation. This is not something that's going to resolve on its own. Once you twist the spermatic cord, you're blocking not only blood supply, but you're blocking nerve supply to the testes, which means it's definitely at risk for ischemia and tissue death. So it's definitely at risk for ischemia and tissue death. Now, let's go over why would this even occur in the first place, okay? So they do believe that, again, this is more common in boys that are going through puberty. Okay. So some of these things just kind of happen spontaneously, or, not to make a joke, maybe they're discovering themselves. So some of these things may develop. And on top of that, this can also occur with adult males, but more so when this occurs with an adult male is usually because of an injury, okay, or some sort of trauma. But with puberty boys, it's just spontaneous. Okay, so that's a picture of what it looks like. And that looks painful. Okay, you can imagine twisting of the spermatic cord, again blocking the blood supply and nerve supply to the testes. So, occurs primarily, again, in pre-puberty males. Severe pain on one side of the testes, thank God it's not bilateral. Swelling of the scrotum, and they will also become very ill, nausea, vomiting, okay, accompanied with this. You can also do an ultrasound here to determine, okay, the amount of twisting and to actually see it, okay. So ultrasound, keep in mind, is the diagnostic test of choice to look at any type of testicular condition. Okay, so treatment. Now I'll tell you a couple of things of treatment, and I've heard a lot of different things on how they treat this. Number one, they treat this obviously based on the severity. Okay, so I don't know if anyone in here works in the field. Have you guys ever heard, anyone ever heard of this condition and heard of how they do the surgery? No? Okay. So, from my understanding, they have to put the spermatic cord in a detorsion, so untwist it, and they use surgical clips and they hold the spermatic cord down to the wall of the scrotal sac. Now, I've heard two stories. I've heard that sometimes patients, if they can, I guess, kind of manage it right then and there, they can take the surgical clips out. And then I've heard stories where patients leave the hospital with the surgical clips in, okay, to keep it clipped down. So I guess it depends on the severity of what happens. Now, another issue when we talk about surgery and taking care of this. Say, for example, if this isn't treated in a timely fashion and we're lacking blood supply to the testes, that testicle, unfortunately, will get necrotic. What type of necrosis do you think is going to happen to that testes? Not caseous, not coagulative, liquefactive. This will be liquefactive necrosis, okay, because it is internal and especially the location where it's at. So it will be liquefactive, which means not only will the surgeon have to go in and, try to take care of the torsion, but they also have to take care of that necrosis and get that necrotic tissue out. And so if it's liquefactive, they can, at least remove it or drain it, okay? So just keep that in mind. It just depends on the severity, okay? And they have here, the torsion is accomplished in 12 hours. Again, I don't know if that's the exact protocol, but.
But this happens in women too, with their ovaries and fallopian tubes?
Yes, it does.
Because it happened to me, it had the torsion in the ovary and fallopian tube, but because it did start dying, they had to remove it.
Oh,
So they
yeah.
removed it when I was like 17, so
Yeah.
I know, but you still have a good prognosis because you
Right.
have the other one that overcompensates for that one.
Yes,
So
that's
does
why.
it overcompensate also?
Yes, the same thing. So, but thank God they do have, it's unilateral. That's what I want to say. Thank God it's unilateral because the other testicle, yes, will definitely take over. Okay, for the one that's if it has to be removed. Yeah. Okay, so the next one we're going to go over now are some infections. So the first infection we're going to cover is epididymitis. Epididymitis, itis, this is an itis, and so just as it says, itis of the epididymis. This inflammation comes from one or two things that I want you to highlight. It can come from urine, a reflux of urine. So sometimes urine can reflux back through the urethra, okay, and kind of go up. And just keep in mind that at any time that you have urine that's stasis or in the area where it's just sitting, we know that that's a really big avenue to breed bacteria. Okay, so they can definitely get an infection that way. Another way that patients can get epididymitis is from bacterial infections. And in particular, the bacterial infections we're talking about here are STDs, the bacterial type STDs. So if you want to jot down chlamydia and gonorrhea. Chlamydia and gonorrhea can cause a possible epididymitis. Chlamydia and gonorrhea. Okay. So, clinical manifestations, the scrotum will be large, red, tender. On blood, or actually urinalysis, you will see elevated white blood cells, and the urine test will be positive for the organism, okay, that they're infected with, and very easy to treat, give them antibiotics, okay, because this is usually most of the time bacterial infection. Now, this next one here is called Fournier's gangrene. So it's telling you in the name, this is a gangrene, okay, so you know what's going on. So this is a severe situation where we know the testes will definitely, the scrotum itself will definitely become gangrenous. Now, this is a rare condition. It doesn't happen just all the time with individuals, but I'll give you two groups of people that are high risk for this, if you want to jot down. Number one, diabetic patients, and number two, patients that are alcoholics. So diabetic patients and patients that are alcoholics, they're actually a little more high risk for this particular case. Now, the reason why they actually have obviously vascular changes, okay, with their bloodstream, as well as having poor wound healing, okay, with these individuals, which, say for example, these patients, most of the times it has to do from an infection. So say for example, these patients develop an infection, and their bodies, because of their disease process of being diabetic or whatever, they can't fight the infection as quickly as a person that is healthy. And so what'll happen now, it will lead into a lack of blood flow, get into the area, lead into a gangrene situation. This we're talking about with males in the scrotum, but I even had a student a couple terms ago told me a situation like this that she found working in a nursing home with a female actually developed gangrene on the labia from an ingrown hair. So just because of the fact that the patient was diabetic, and keep in mind any type of infection or any little whatever, unfortunately not being able to fight it in a timely fashion, and so leading into that type of necrosis. So just keep in mind that these things can happen, even though we're covering for males, but both females as well, as you were saying also with the torsion. Okay, so yes, gangrenous necrosis of the scrotum, they will have pain obviously on that side, fever, chills, swelling, sepsis, so they're gonna have all the signs and symptoms of an infection because that's what the cause is. Diagnosis is made obviously by inspection and history and physical and ultrasound and other imaging. Treatment, if you have anything that's in a state of necrosis or gangrene, please understand that tissue has to be removed. Okay, you would never want to just sit there and think it's going to take care of itself. You have to remove the tissue, so no matter where it's at, if it's necrotic, it has to be removed. So they will take it out, drain it, give the patient antibiotics, and hopefully get the infection under control. So, the next thing that we have here is testicular cancer. Okay, just a few things I want to point out here. I don't want you to go over each and every item. However, with testicular cancer, we know that it's not the top cancer of male reproductive cancers. We know prostate cancer is actually on the top of the list, testicular cancer the second. Okay. Now, when a male develops testicular cancer, I do want you to know the age range. It's usually somewhere between late adolescent and early adulthood. And that's important to know because we know prostate cancer hits later on in life, so over 50. So testicular cancer is early on. Testicular cancer, just
Late
like...
adolescents, so they could be teenagers when they get this?
So late adolescence to what?
I'm sorry.
Can you repeat the age
Yes,
again?
late adolescence
Okay, sorry.
to early adulthood. Testicular cancer happens early on. One major risk factor that we went over with testicular cancer, which is down here, is cryptorchidism. So remember, we just talked about that. So when cryptorchidism, if it goes untreated, okay, this can definitely lead to testicular cancer. Okay, it's definitely a high risk for testicular cancer, and that's why it'll come out in late adolescent, early adulthood. And a lot of it too, from my understanding, has a lot to do with development and why it's happening that early on. Now, just like breast examination, if males know there is a history in the family, they can also do self-examination of the testes to also check for nodules and things like that. Now, as far as treatment, you can cross out this slide, I should have took it out, but treatment is going to vary depending on the severity of it. Yeah, I don't really usually get into each and every item here. The types of cells and if they're doing radiation for one and not the other. We don't need to get into that because it all depends on the stage it's at.
Yes.
All right. Now, BPH, this is a big one. BPH is actually one of the most common male reproductive disorders out. Very common, so much that I always tell the males in the room, there's a high chance, okay, of males developing this. That's how common it is, okay, unfortunately. Now, benign prostatic hyperplasia, what it means is this. The prostate gland increases in the number of cells, which is why they call it a hyperplasia. Although some books you may look at, they call it a hypertrophy, which it will lead to a larger organ, yes, but the cellular adaptation is really a hyperplasia. Okay, so the number of cells increases. Of cells. The number of cells in the prostate gland increase in number, which makes it larger. Now, why does this occur? What is the issue here? Why does it happen to these men when they get over 60? Okay, and now leading into this. Some books that you read, they say that there's an unknown cause, we have no idea, okay, it just happens. Although some books that you will read will say the cause has to do with males having a decline in testosterone. Okay, and that makes a little more sense to me because it is happening around that age group. So once they are having a decline in testosterone, the prostate gland actually tries to compensate by, or goes through this compensation, by increasing the number of cells. Now, the prostate gland, this is the situation. If you have the prostate gland getting larger and larger and larger, you know from anatomy what runs through the prostate gland? The urethra, which means that if the prostate gland gets larger and the tissue is thicker, it's actually going to squeeze on the urethra. If it squeezes on the urethra, this is definitely going to block urine flow. Not only urine flow, but something else I want to add, I forgot to tell the other section. What else is being blocked? Semen, thank you, because keep in mind that the urethra is actually an orifice for not only just, or conveys urine, but it also conveys semen and seminal fluid. So if there's a blockage, a cutoff, okay, that's going to definitely alter what's supposed to be going through. Now, the major thing that they are kind of focused on with BPH is the urinary issues, okay, because what happens is this, the urethra is blocked, which means that urinary retention is developing, okay, so the more urine that's being retained in the bladder, we know what's going to happen. Infection, yes, it can definitely lead to bacteria and infection developing. So these patients can definitely get a lot of infection, or they will actually have UTIs, signs and symptoms of UTIs. And they will also have obstruction of flow, decreased stream, hesitancy, difficulty. So they're going to have all the signs and symptoms of a UTI, basically. Okay. And keep in mind that the more that this continues, understand where else could this infection go up to? Up from the ureters to the kidneys. Okay, so please understand that this infection, if it continues going on, it will go up the ureters into the kidneys and now continue on and cause a kidney problem if it goes untreated.
So let's say those 3 middle bullets there are signs and symptoms of a urinary infection?
Yes, you can say that, but they believe that it's because of the BPH. It wouldn't be occurring if it wasn't for the BPH.
So would it be like a hallmark of the BPH?
You can say it's a hallmark. It's just part of the disease process. Now, another thing I need to add here that's not on the PowerPoint. What is the function of the prostate gland that you guys remember from anatomy? Because the prostate gland is having an issue, so we also have to look at its function. Very good. The prostate gland helps make seminal fluid. Okay, it actually helps make a good portion of seminal fluid. Which means that if the prostate gland is in a state of hyperplasia, having issues, it's not going to be able to make or kick out the amount of seminal fluid it's supposed to. And to be exact, the prostate gland actually makes the alkaline portion of seminal fluid. It makes the alkaline portion of seminal fluid. What does that mean? Not too descriptive, but it gives semen its white color. And so what happens is this, if males do have prostate issues, when they do have an ejaculation, seminal fluid comes out. If the semen is clear, like all the time clear, that's kind of a telltale sign that something is wrong with the prostate gland because they're not making enough of the alkaline portion of seminal fluid. Okay, and they'll tell you that if you have a consultation, they'll tell you what's going on. So urinary as well as seminal fluid issues. Now, diagnostic tests, so rectal exam, sometimes also known as digital rectal exam, depending on what book you're looking at. You guys, from my understanding, don't have to perform this. So what happens with a rectal exam, as it's done, it's used to kind of sweep across the prostate to feel it, to actually feel for enlargement, and to also feel for nodules. So if a rectal exam is done and they feel the prostate gland and it's actually larger, okay, than what it needs to be, most likely it's a BPH, or sometimes it's larger too if it's prostatitis, which was more related to prostatitis, if the prostate gland is just inflamed. Now, if a person has prostate cancer, when they feel across the prostate gland, you'll feel where the tumor is located. Okay, so there'll just be one area that's larger. So that's what they're looking for. Now, bladder scanning and urodynamic studies, those types of tests are done to see, obviously, the backup of urine and the issues that are occurring. So you can know the exact location, how much urine they're getting out, okay, if any at all, okay, those types of tests. And treatment. Treatment for BPH, they do have a couple of things. So alpha blockers, also known as 5-alpha reductase inhibitors, these are meds that are given to actually relax the muscle of the prostate gland. So they actually relax the muscle of the prostate gland. And if you relax the muscle of the prostate gland, that takes off the pressure from the urethra. Okay, so it kind of calms the situation. They also have something called microwave therapy and needle ablation. Okay, not that they're going in a microwave, but this is more of sort of like a wand. And so it's just there to try to reduce some of the tissue. And surgery is there used to remove the tissue completely out, okay, from the prostate gland. So there's a picture of the prostate gland there and the urethra that runs through it, here in the bladder, so we know the anatomy. Now, this is another picture that's very interesting. So, remember how we said that urine can back up, and they're trying to show you here that, it's squeezing, okay? So imagine that it's squeezing and it's a backup of urine here in the bladder, okay? So imagine this patient having BPH, having this situation, and it goes untreated. Okay, they don't treat it in a timely fashion. Where's that urine going to go? It's going to keep going up and up and up. So understand that the kidney is still making urine. So keep in mind they're still eating and drinking, and the kidney's still doing what it's supposed to do. So they are continuously making urine. If they don't have a way for urine to get out, that urine is going to actually build up. So it'll build up in the ureters, which is what we call, I don't know if you can see that, hydroureter. So hydro for water, ureter in the actual structure. So hydroureter, so the urine will actually build up there. And hydronephrosis. Hydronephrosis meaning that the urine will actually build up in the kidney. And the kidneys become larger. And again, if this goes on too long, this is definitely going to alter kidney function and cause a whole bunch of issues with the kidney. The next one we have is prostatitis. Prostatitis, this is an itis of the prostate gland. Most of the times this is due to a bacterial infection. Okay, so I do want you to know that it's usually due to a bacterial infection. You don't have to go over and memorize each and every organism. I'm sure you did that in micro. However, just make sure you know mostly bacterial infections. We're going to focus on the routes of entry of how these patients can get this infection going all the way up into the prostate gland. That is important because, believe it or not, these are some things that can possibly be prevented, okay, in the hospitals from the routes of entry. Okay. So, a couple of things here we're going to go over. So we have ascending from the urethra, direct extension coming from the rectum, descending from the bladder or the kidneys, and then also hematogenous already in the bloodstream. So let's go over ascending from the urethra first.
These are all the routes of infection.
These are all the routes of entry. All the routes of entry. So it can enter from the penis, the rectum, the bladder or the kidneys, or already from the bloodstream. Okay, so these are the routes of entry. And we're going to go over each one so we can talk about some scenarios as to how this could occur. Okay, because that's important to know. So now let's go over the urethra, ascending from the urethra. Now, what type of situation or scenario do you think that a male patient can get an infection around or enters through the penis that goes all the way up through the urethra Going up to the prostate gland.
Yeah.
Catheter, very good.
STD.
STDs. And let's also add in there what is actually common amongst our geriatric patients sometimes. Not exactly that.
Ovaries.
Well, let's just say poor hygiene. Okay, poor hygiene. It's very, very common amongst the elderly community, not only just the males, but also females as well, to have poor hygiene. Keep in mind, when they get to a certain age, they cannot, take care of themselves like they used to. Sometimes we know if they are not with the catheter, or even if they are in a catheter, sometimes certain things aren't changed in a timely fashion. Even if they're not in a catheter, if they're going to the bathroom themselves, okay, or in a bedpan or whatever, sometimes things aren't changed and cleaned in a timely fashion, now leading them to having an infection. Okay. Sometimes families always want to know, okay, why is it that grandma always has a UTI? Okay, and the reason why is because of the poor hygiene. Okay, that happens sometimes. Now, that's that. So, going to the rectum. What are some scenarios that can cause an infection? Let's say some sort of organism getting through the rectum and maybe extending over to the prostate gland. STDs, very good. E. coli, yes, and again from, let's just say, poor hygiene, that goes along with that. So this one is another one that's going to be from poor hygiene and STD. So both are actually from sexual activity. So sexual activity for both the urethra and the rectum for STDs, excuse me, and poor hygiene. Descending from the bladder or the kidneys, this one's pretty easy because of where the location of the prostate gland is located. It's located right below the bladder. So if a person already has a bladder infection, okay, it can spread right to the next organ. Okay, so that's easy enough. And then hematogenous, this is where a person has a bacterial infection already systemic in their bloodstream. So let's say a person already has sepsis. And if this patient is septic, it is a possibility it can just spread to that organ.
So hematogenesis already has an infection in bloodstream?
In the bloodstream. So more example is sepsis. So we can just say like a sepsis case.
And then what did you say about bladder or kidneys?
That infection, if it's an infection in the bladder or the kidneys, and especially because of the bladder's location, it'll just have a direct extension because the organ's sitting right next to it. So even if it's like E. coli or whatever it is, it's causing the infection. Okay. So clinical manifestations. When they do have prostatitis, it is an itis. So they're going to have signs and symptoms of an infection: fever, chills, low back pain. Let me write this down for you now. Please understand that low back pain can actually mimic anything in the abdominal pelvic cavity. Okay, so it can be anything that's GI related, anything that's related to the renal system, or anything that is related to reproductive. And that's important to know because sometimes people come in and, oh, back pain, and we can't just automatically think it's a musculoskeletal issue. But keep in mind that back pain, most of the times are related to these types of situations because of the pain referral pattern. Okay, did you guys go over pain referrals and anatomy? Okay, so there is something called viscerosomatic pain, meaning that if there's a pain or issue, or I should say an issue at the viscera or the organ, that is a referred pain that will go to the somite or the muscle or the tissue, okay, the muscle or the bone related to that referral pattern. So, for example, GI, let's say, for example, patients that have colon cancer. What is one common symptom they have with colon cancer is low back pain. Very low around the sacral region. Renal. One thing, kidneys, which we know because of their location, and so whether that patient's having a kidney stone going on or even an infection, they're definitely going to have low back pain. Reproductive, prostatitis, but let's go to females. Okay, we know just normal menstrual cramps sometimes can give back pain. Endometriosis can give back pain. Ovarian cysts. Okay, so all of those things we know can have that referral pattern to the back. So just keep that in mind. That's usually associated with that. Frequency, urgency, and dysuria. So they will have difficulty urinating, obviously, because the prostate gland is inflamed. Okay, and it's also blocking urine a little bit, just like BPH. And rectal exam, as I told you before, when it's done, they're there to feel the prostate gland to see the enlargement, and also it's going to be tender. Okay. And with chronic prostatitis, the pain is actually worse, more back pain that they have, and even in around the region. Okay. So when a urinalysis is done, you'll definitely see white blood cells elevated to fight the infection. Okay, the bacteria will also be there. And treatment. Antibiotics, I do not need you to memorize that type of antibiotic. That's not necessary for us right now, but just know antibiotics will be given to them. Anti-inflammatory agents, other things such as alpha blockers, which we know is going to relax, unless you relax the prostate. Prosthetic massage, I don't think you guys have to do that, so you don't have to worry. Sit baths, okay? Now, I have an issue with sit baths, even though they have it listed here. Do you think a sit bath is actually something good for these individuals?
No.
No, okay. And the reason why is because they already have an infection. We're trying to fight this infection, and we don't want these individuals sitting in warm water, okay, which we know breeds more infection. So just keep in mind that even though they have this listed here, just obviously to make them feel better, kind of soothe the area. However, it's really not a good idea, okay, for this person undergoing an infection.
Would that be a treatment of like an older generation doctor compared to like more modern doctors? Like newer
Probably, but I think, and this is the problem, sit baths are okay if people do them, especially at home, if they do them the way they're prescribed. So you're not supposed to sit in the water, you know, all night. And what happens usually when people are told to do sit baths for whatever reason, it's for a short period of time, maybe 30 minutes or 15 minutes or so. But some people stay there longer than they need to. And so that's the issue. And then the longer you sit, the more issues can occur. Again, I don't know if they actually still use this right this moment, but they have it listed here as something to just kind of help. And it's just to help the pain. It's more like an analgesic. It's not going to help the actual situation, but just kind of help them feel better. Okay. And then the very last one I think we have to cover here is prostate cancer. Prostate cancer is the most prevalent cancer we know in men, as one of the top reproductive cancers in men over testicular. They give you some of the percentages, the cases here per year, things like that. You don't have to memorize all that. However, I do want you to know that the age group is targeted to over 50. It is targeted to males over 50. The etiology is unknown, which we know for all cancers, and they don't really have a particular risk factor for this one. This particular slide, 61, I do not need you to know the different stages. You can cross that out. Yeah, you can cross out all of them. And it's just saying the degree depends on the severity. We know that how aggressive it is how aggressive you got to give a treatment. This I do need you to know. So the way this is diagnosed, rectal exam, which I already explained to you what they're looking for the feeling for the tumor. Biopsy obviously is the most definitive way, okay, of telling if the person has cancer by looking at the cells. Serum-specific antigen, PSA, we've seen this before, okay, and we know that this is the tumor marker. This is the tumor marker for prostate cancer, as well as rectal ultrasound can be done to see the actual prostate and the thickening of the tissue. Now, treatment. Treatment again depends on the stage. Okay, now I know they have watchful waiting here that really should be taken out. However, from my understanding, prostate cancer, if it's caught early on, it is better to put those patients into a remission, okay, some sort of remission. If it's caught later stages, not such a good idea. Unfortunately, they do catch most cases of prostate cancer kind of more in the later stages. Why? Because sometimes men don't go to the doctor in a timely fashion, okay, or go to the doctor as much. They say look at their health care as much as women do. One of my friends, his father died of prostate cancer. He was having issues, and so signs and symptoms, they will have some signs and symptoms similar to BPH, okay, just to let you know. So it's not like they'll be kind of in the dark with what's going on. So they'll have some signs and symptoms as it's progressing. Unfortunately, he ignored those signs and symptoms, and he did not go to the doctor until he started bleeding from his rectum. And that's when they diagnosed him with like I think a 3 or 4 at that time. So just understand that when it gets to that point, okay, where tissue necrosis and death and all that start to occur, they can only just do what they can do at that time. So again, treatment all depends on the stage. Okay. We're done. Either way, we're going to continue on with our reproductive chapters, and we're going to continue now with chapter 32. Chapter 32, this chapter actually covers development, and so the first thing we have to go into is early human development. Please understand that this chapter is kind of like an added-in chapter because we need to, God bless you, make sure that you're actually prepared and more comfortable for peds, okay, when we do get into peds. When you get into pediatrics, they'll go into all the different types of disorders and things. There's a lot of terminology that you'll have to cover with that. However, we want to just go over what happens with development because we all know that we start off as one little cell. So we're going to talk about how we start off as one little cell, now developing into this human being that we are. So we do have to go into detail with that. Okay. So with early human development, we do want to cover the first, what happens after the first 24 hours after fertilization. So what will happen, if you remember, anybody remember the movie Look Who's Talking? Sperm, it's an egg, and it gets in, and boom, here we go. So now once fertilization occurs, what's happening after that? Okay, so once now that we have this fertilized egg, it's actually going to go through a series of events, okay, to form this nice, wonderful human being that we are. Now, after the first 24 hours of fertilization, it is considered a zygote at that time. And so this zygote will actually undergo mitosis. And what we mean by that is we know mitosis is cell division. So that one little cell actually has to undergo many types of cell division, or actually many stages of mitosis in order for it to develop into an actual fetus. Okay, so we'll get to that point. Now, the first stage of this mitotic division that occurs is what we call cleavage. Cleavage is where you have a 2-cell zygote that actually divides into multiple times. So it goes from 2, 4, 6, 8, 10, so forth. Okay. Now, the whole point of this happening is the embryo is actually formed when the cytoplasm partitions into specific types of cells. And that's key because what's happening here, if we're now forming these different groups and different sets of cells, what do you think they're going to differentiate into? They're going to differentiate into different organs. Okay, so this is where organ development begins. The embryo is transported through the oviducts to the uterus. I'm going to touch on that again because what I need you guys to know, and I think we know this, that sometimes when there's an issue, say such as ectopic pregnancy is when there is a development of that zygote into trying to develop into a fetus, now in the oviduct where it should not be developing there. And it actually should be migrated towards the uterus, okay, or to the uterus, and that's where the rest of the development should be taking place. But ectopic pregnancy is where it stays in the actual tube. So, here's a couple of examples here. So there's, like I said, a 2-stage, 4-cell, 8, okay, and what they call a morula. So a morula is just a big ball, okay, of cells. And the next thing that happens after the morula stage is something called a blastocyst. A blastocyst, as you can see from this picture, there are cells that actually differentiate to some at the top, some surrounding, and then there's a really hollow area or cavity right down the middle. And this is very important because this is actually where our first tube is actually going to be formed, okay? So this actually starts the formation of the tube. So implantation occurs on the 7th day after fertilization. And what we mean implantation is implantation into the uterus. Okay, implantation into the uterus. So as we know, again, these cells are dividing, they're dividing along the oviduct, but then there's going to get to a point where we actually have this ball of cells now migrated to the uterus. And please understand that these cells, or the zygote, is actually sitting on the wall of the uterus. It's not sitting right in the middle. It's on the wall of the uterus first for a time period until the placenta is formed. Once the placenta is formed, then it can move to the middle. Okay, so I want you to understand it's actually on the wall of the uterus. So fetal membranes, these membranes help protect the embryo and fetus, okay, and provide substrates for growth. Okay, so again, it's on the wall for that protection. And so this kind of looks like an 8. It is 8, but the yolk sac they're showing you there, the endometrial lining, and so just kind of showing you how it's attached. Okay, so it's attached at that stage, what we call implantation. After, and so let me backtrack too. I know I'm giving you a lot of information, but remember how when the corpus luteum actually, when the egg is released during ovulation, the corpus luteum is there. Understand that when a female becomes pregnant that month, the corpus luteum stays and actually starts secreting progesterone. That progesterone is needed heavily for the uterine lining, so the zygote can attach there. Once enough progesterone is there and everything's fine and we continue on with the process, once the placenta is formed, it now moves to the middle, okay, of the uterus. And this is where HCG, okay, is also, well, HCG is part of it along the way, but HCG is also help protecting, okay, what's happening with the placenta. So, fetal lifeline, the placenta is very important, and it is the fetal lifeline because the placenta is actually the fetus everything. Okay, so this is where blood supply comes from, nutrition, waste, everything you name it actually goes through that placenta. Secretion of HCG is also important because HCG we know is actually secreted when the female is pregnant, and we know that's actually one of the first things that are done as far as testing, because we know that this particular hormone is produced after fertilization has occurred. And so once this hormone is produced, this now helps estrogen, it's the secretion of estrogen and progesterone to actually help the whole process of pregnancy, okay, to help the fetus. The placenta secretes estrogen to promote uterine enlargement. This is important. Why does the uterus have to stretch out? Well, we're about to form a big baby, okay? So it has to get ready to prepare to stretch. Breast growth. Also, elasticity of pelvic ligaments. This is very key. Sometimes people tend to forget this, but the pelvic cavity in the female actually has to move, okay? One of the joints, it is sort of, sometimes they call it a syndesmosis, meaning that it doesn't move, but sometimes those joints are movable, but have very tiny, tiny movements, especially right at the pubis. And the reason why they have this little tiny movement, believe it or not, is so it can get ready for delivery, okay? So sometimes when females are pregnant, they will have sometimes back pain, sometimes pelvic pain and pressure because of the weight of the fetus, as well as just the fact that those ligaments are stretching. Even sometimes after they deliver, they'll still have some kind of pain in that region or discomfort because the ligaments are now trying to go back, okay? And so they will have some discomfort. And then progesterone. Progesterone helps prepare the breast for lactation. That's important to know as well. And to add to that, what other two hormones we know are important for lactation? Prolactin and oxytocin. Very good. So make sure you also add to that, prolactin and oxytocin are also important for lactation. One secretes the milk and the other one lets the milk out.
So oxytocin secretes it, the other one produces it.
Prolactin secretes it, oxytocin lets it out, lets the milk out. Okay, so fertilization to the end of the 8th week. Now we jump from a zygote to an actual embryo. So here we go with the terms. Okay, and then you'll get more terms when you get into Pete's because they have different terms there. So now we call this an actual embryo at the 8th week. And from the 9th week until birth, we call this now a fetus, because when we have the term now fetus, this is where you can start to see actual visible features, okay, of the child. So the eyes and the nose and the arms, digits and things like that. So for the first month, there is rapid growth. They call this a morphogenesis. And so if you if you read some books, they say that it kind of looks like a tadpole in the beginning, and then it starts to kind of change into this sort of little human being. The hard tissue is differentiated, so please make sure you know that's one of the things that actually develops in the first month. Also, another thing that develops in the first month of the fetal development is the brain. So 3 primary vesicles of the brain are formed. And they really should have had this at the beginning, but the very, very first thing that's formed in a fetus is the actual nodal cord and neural plate, which means that the nervous system, okay, is actually one of the first things that begins to develop. And we know that from chapter 2 that that's very important to have the nervous system, okay, because the nervous system controls what? Everything else. So we would imagine we would need that development to happen first. Okay. So here we go, that little shape that we were talking about. Okay, so there's so the head looks very large, okay? Kind of takes up a little more circumference than the rest of the body this way. However, it's still forming. Eyes, okay, opening for the ear canal. You can see the digits, although the arms are not fully developed as of yet, okay? And also the same thing with the feet, okay, and then you see a little area there for the umbilical cord, okay? Because by this time, the umbilical cord placenta is completely formed, so this fetus can definitely get all the nutrients it needs and blood supply so it can continue to grow. So 2nd month, organs continue to develop. The embryo is more capable of movement now, so maybe some slight movements can occur. Blood vessels assume their final position. The heart is now finalized. And the brain will actually start to transmit impulses, which is a good thing because this is how the fetus can have those little movements, okay, because of the impulses. And a few reflexes. And the ovary and testes begin to form. And I always forget, I think by this month, you can tell the sex of the baby. Actually, I think, don't they have it early now? I think before that. Okay, you can tell the sex of the child.
Is there like
Just to make sure, but now they have those 3D type of ultrasound. Okay, so the 3rd month, eyes and ears finally reach their position. As you saw before in the picture, they were all kind of towards the front. Okay, and so now they move to laterally to the sides, okay, where they're supposed to be in equal distance. Some bones may be distinct. They do have breathing movements, but keep in mind because of their location, the fetus, what they're breathing in and out is amniotic fluid. They are not breathing, obviously, air. Babies also carry on sucking movements here, which is a good thing, and you want them to have to actually start practicing suckling, because that's what they're going to be doing to feed when they're born. And they give you the length and the weight there.
Do we have to memorize that?
No, you don't have to memorize the weight. Okay, so second trimester, 4 to 6 months of development, achieves independent mobility, moves freely throughout the amniotic fluid, so this is a time where you can definitely feel that movement, okay, of the fetus. The heartbeat is also very, I don't want to say palpable, but you can hear the audible of it, which when females go to the doctor at this time, they can definitely always hear with the heart monitor and listen to the heartbeat at this stage. Third trimester, the greatest amount of growth occurs. They say the weight almost doubles in the last 2 months, because we got to get ready, come out to the outside world. So they have to hurry up and get things together. And so there's final differentiation of organs and tissues. So this is a table going over all the things we just kind of went over. Now, keep in mind, and we know that prenatal care is important, obviously, throughout the entire pregnancy, but you can just see the amount of changes that really occurs just within the first 2 months. That's why prenatal care is so important and very important, especially in the beginning, because you don't want these moms drinking and smoking or whatever, and making sure they have proper nutrition, because a lot of important things are happening here. Okay, so that's that. And now, the next thing, you get you. So once the fetus is developed, and we're fully developed now at the end of the 9th month, okay, now we're ready for the outside world. Okay, so now let's go over what happens with delivery. So we know that some terms here, we know labor. Labor is the actual process of going through the contractions and the uterus actually contracting and so forth to get prepared for delivery. Delivery is the actual expulsion of the fetus. Now, they do have another term, okay, this is a clinical term called parturition, and this is basically, again, just another term for the delivery process. So the process in which the infant is born, the uterus progressively becomes more excitable and allows strong rhythmic contractions. Okay, so the uterus gets excited. So what they mean by excited is that the uterus will actually continue to contract to the point that it will now help push the fetus out. What actually helps those uterine contractions? There's a particular hormone that's oxytocin, very good. So keep in mind, oxytocin is also part of this process with delivery as well as lactation. So progressive hormones will change, and progressive mechanical changes will help the excitability. So hormones will change. We will increase the rate of estrogen that is released, causing a contraction. Constant and decreased progesterone will also inhibit uterine contractility, and oxytocin, as we just said, will also help with those contractions. So mechanical changes. So there is a stretch or irritation, they say, of the fetal head up against the cervix, okay? And this is where we know that whole term dilation comes from. So as the fetal head is approaching the cervix, okay, or moving through the cervical canal, this is now where the dilation begins, okay? And they can determine how many centimeters or so forth. So the whole physiology, excuse me, the entire physiology here is this. As the fetal head approaches the cervix, what that does, as it continues, it actually will stimulate more hormones to be produced, in particular oxytocin, to cause more contractions. So the more the fetus is pushing, the more the body's making contractions. And so it's almost like this positive feedback loop that's occurring. So cervical stretching stimulates the release of oxytocin. Oxytocin will cause uterine contractions. So each one feeds off of each other. Okay. Metabolism. Oh, this is now pregnancy. So what happens to the mom's body as she undergoes pregnancy? Okay, we all know there's some dramatic changes, okay, as well as weight gain. So increase in basal metabolic rate, There is definitely an increase in secretion of hormones. So sometimes these hormones can cause different, I don't want to say signs and symptoms, but yeah, kind of signs and symptoms as a result. So sometimes, believe it or not, the skin, sometimes with females when they're pregnant, can actually turn a little bit. They can actually have an increase of hair sometimes, depending. So a lot of different physiological changes can occur, and that's usually due to the hormone release. Okay. Results also in alteration of many organ systems, so the circulatory system, respiratory, and definitely urinary. So these systems will adapt, and which we're going to go over those in a
Do
second.
we have to know exactly what those hormones do?
No, you don't. But I just
Do
want
we
to give
have
you.
to know the names?
Yes. Know the names just to be on the safe side. But I just gave you some examples just so you'll know. Like signs and symptoms, what comes from that. Because when we say, for example, increase in sex hormones, well, yes, they will increase in estrogen and progesterone, which is needed for the fetus. However, sometimes the testosterone levels will also kind of be part of that too. So let's say a sign and symptom of that is what comes from hormonal changes. You know, so I don't want to say mood swings, but you know, so things that come from hormonal changes. Okay, now circulatory system. What can happen, because we know that the placenta is needed to give the blood supply to the fetus? Understand that these moms are actually going to increase in their blood flow. So cardiac output is actually increased tremendously. Not only do they need enough blood supply for themselves, but they need enough blood supply to the baby. So they will actually increase in the volume of blood and circulation. Okay. They even say high uterine blood flow and decreased cardiac output slightly above normal in the last 8 weeks. Okay, so again, to help with the fetus, and increased fluid retention to the kidneys. So if we're increasing blood flow, keep in mind that this is also going to alter, you know, what's happening with the kidneys. So the kidneys will also now increase in fluid, which is part of the running to the bathroom. Okay, so not only if they're running to the bathroom for two things, they're increasing their urine output, and on top of that, the fetus most likely is pressing on the bladder. So there's two reasons why they're constantly going to the bathroom. And increase in bone marrow activity. Red blood cells, yes, so we need more blood. Okay, this is a chart, you don't need to memorize this, but just to show you how the blood volume actually increases tremendously up until the time of delivery. Okay, so it will increase definitely getting ready in those last few weeks, okay, to get ready for delivery. Respiratory system is also part of this. So what happens in the respiratory system? Obviously, if we're increasing blood in the circulatory system, we would imagine that we're going to have more oxygen, correct? So these females will definitely have more oxygen, okay, that's actually being distributed. And decrease in diaphragmatic excursion. So let me explain that. So even though the oxygen flow is increasing and it seems like respiration is high, their diaphragmatic excursion is going to be smaller because what do you have here? You got the baby bump in the way. So the baby bump is now going to cause more pressure on the diaphragm area, which means that now they can have a decrease of that diaphragmatic excursion, that A to P movement. Not to say that they're having issues breathing, it's just decreased because of the fetal development. When we get into GI, I'll tell you an example of one situation. A student a couple of terms ago, she was pregnant with triplets. And it actually caused a lot of pressure, okay, on the diaphragm area to the point that she actually developed a hiatal hernia, okay, from the triplets. So understand the growth, okay, or the weight, okay, can really put a lot of pressure there. So, urinary system. Increase in tubular reabsorption of sodium and water, okay, you don't need to memorize that exactly. However, increase in glomerular filtration rate. Yes, again, this talks about adding to the urine output. So if you increase glomerular filtration rate, you're actually going to have more urine that's going to be produced. And reproductive organs. We know that the organs and breasts in particular actually increase in size, especially the breast for lactation. Weight gain, we know, yes, because you're eating for two. And so keep in mind that the mom needs nutrition as well as the baby, okay? And they need it almost double the amount in order to get proper nutrition. Increase in appetite as well, and increased need for vitamins and supplements. And I think we all know that prenatal vitamins are very, very important, not only to protect the mom and keep her healthy, but also to make sure the fetus has those proper nutrients, okay? If they're not getting everything.
Is that true that you are really eating for two? Because I've heard both sides that like you're not supposed to double eat, but then
Yeah, you're not supposed to really double eat, so, yeah. Because people like to use it as an excuse.
Yeah, that's right.
However, you are eating for another person, so you may increase, not to say you're supposed to have like 2 plates, but
A little bit
you're
more.
gonna increase more food, definitely. Definitely increase more food. Okay, so, I know this is weird when jumping to menopause, so. Yeah, give birth, life goes on, and then menopause. Okay. So, now we're jumping to menopause. So, menopause occurs somewhere around 45 to 50 years of age. Okay, where it starts, and I hate to look at that. I haven't had children yet, so I'm gonna be one of those getting close to the right in the middle. So, however, perimenopause, they say, starts around 45, somewhere between that age. So every person's different. Some people, doesn't happen till they're 50, some people it happens a little early. So what happens with menopause is this: it's where you stop the cycle, okay, stop the menstrual cycle. And so please understand that this stopping or cessation of the menstrual cycle is not something that happens like cold turkey. Okay, so I want you to know it's a process. It takes a little time for this to develop. So it is a decline, okay, in estrogen and progesterone, leading to an irregular menstrual cycle. That is key to know, leading to irregular menstrual cycle. The reason why we're making a big point of that is this: sometimes when females are going through perimenopause, like the beginning stages, they'll stop having a cycle, they think they're good to go, and then unfortunately 3 months later, here we go. Here's a menstrual cycle. And then they're wondering why, and it may happen for another 2 or 3 months or so, and then it stops. Okay, so it kind of goes through this sort of waves, so to speak. Very important to know and be careful, because believe it or not, I've actually heard of cases of people becoming pregnant during perimenopause. Okay, so they're thinking they're done, and here we go, they're pregnant. And it's because the cycles are irregular when it's going through that process, so they really have to be careful.
My boss was 47, and she thought she was in menopause. She's like, "Oh, I'm in menopause," and then like 2 months later, she's pregnant. She's like, "I don't know what happened."
Yes, I one of my old neighbors, that actually happened, and we were carpooling to go to work, and she was crying in the car like a baby.
She was
And
crying too.
she was so upset because their youngest was in college, and here we go with a baby. So it happens. Okay. So again, it goes through this process. So it's irregular in the beginning, and then it gets to the point where it completely stops. Okay, so it gets to a point where it completely stops. Permanently. So, again, perimenopause is the stage that we were just talking about, where it's kind of tricky and you might get pregnant, okay? So this is the stage where it's the phase prior to the onset of menopause with the irregular cycles. Again, that's the key, it's irregular. And most women do have the decline in estrogen. Now, keep in mind, when it gets to the point where there's a complete decline in estrogen, what they call climaceric stage, this is where it actually completely stops permanently, okay, and then you're good to go. Now, with this situation, understand that the uterus will actually start to shrink. So when females go through menopause, the reproductive organs will shrink, because we don't need the hormones aren't there to actually give it activity, okay, for the activity of those organs. Signs and symptoms, I think we all know the common hot flashes, okay, with menopause. So hot flashes, joint pain, stiffness. Sometimes the sleep pattern is disturbed, but they can also like kind of wake up in a cold sweat, okay, because they're hot and they're cold and hot and cold, and so it kind of goes back and forth. Changes in GI, palpitations, things like that. So some structural changes that can also occur during menopause, and this also has to do with aging. Osteoporosis, I think we all know the combination, and not to step on anybody's toes. Did anybody pick osteoporosis for their presentation? Okay. So with osteoporosis, we know that as there's a decline in the reproductive hormones in females, this actually is a very high risk for them developing osteoporosis, okay? And so there's the link to that. Thinning of the skin can occur, which is also part of that aging process. And atrophy of the vaginal structures and breast tissue. So if you don't have hormones that's being produced, the reproductive organs kind of are in a state of atrophy, or they're declining in their function. So another thing that occurs, they have it here, maybe the next slide. No, let me just say it here. The vagina actually becomes very dry. So what happens, the secretions are actually now decreased because there's not enough hormones, and so all those sexual things are not happening, okay, as they're used to, because of the fact that the hormones are decreased. Same thing with the breast tissue as well. So, the aging process. As females age, we know that there is a decline in the reproductive hormones, okay? However, each person is different and depending on what age. So, don't forget that in order for us to have a decline in estrogen and progesterone, there first has to be a decline in LH and FSH. So remember from physiology, the endocrine system, LH and FSH from the pituitary gland. If we didn't have those two hormones, we will not have estrogen and progesterone, okay, because we need those kind of precursors. And so another thing too, there's an increase in breast fibrosis and calcification. Breast can also decrease in size, and the ducts are replaced by fat tissue. Okay, so now the lymphatic, mammary ducts, okay, for lactation are actually now replaced with fat. Okay. And, oh yeah, here it is. So the uterus, cervix, atrophy, so everything gets small. The uterus is small, the cervix is small, so everything is just going back, okay, down. And even the elasticity of the vagina decreases, okay, so it's smaller, there's loss of secretions, reduced size, all of that. What's that? I know. I know, it's like something to look forward to.
It's close, if you think what's like this.
I think we'd be done before.
Yeah, absolutely. Okay.
Do you want the $45 one? You're like, well,
Cool with that.
well, her most expensive.
Okay, let me ask you this question now before I forget. I was told that you guys have orientation again tomorrow. And so I normally have my tutoring on Thursdays at 1 to 3. And what time is your orientation in?
12:30, 3:30.
So do you guys want me to do the tutoring after 3:30? Or do you want me to move it to another day? I don't know how to do this now. And I usually like doing the tutoring like, you know, at the end of the week to get ready, you know, definitely before the weekend.
How about Friday?
So you guys can study. Is Friday okay? I can do Friday. Will everyone be available Friday for those of you? Because I know quite a few of you in this class come to tutoring. Friday morning or afternoon, I don't know.
I'm good with whatever.
Friday's a little tricky. Ready for the weekend. Let's say Friday, 10 or 11. Is that okay? All right, let me just confirm with the afternoon class, and then what I'll do, I'll send out an email, okay, with the exact time. Because I know if I do it, I can do it Thursday afternoon, but I know that's a long day, okay, for you guys after the orientation. Right, okay, so then I can do Friday, okay, and so I'll confirm the exact time. All right. Oh, yeah. Is it, did you do it yet?
Yeah, we all are going to start.
When's the deadline?
It was Thursday.
Oh, really?
But they're supposed to send emails about stuff being rejected. So, white hairs.
It's funny, I used to sit on
So they ready to go?
Yeah, I need to. Okay, let me get to 33. Let me get to 33. So, 33. Chapter 33 covers female reproductive disorders. So, with this particular chapter, we're going to cover all of the female reproductive disorders. Most of them are actually common, so there's more we have to cover than male reproductive disorders. The first couple of slides I'm going to try to breeze through just to kind of highlight a few things because it actually goes over more terminology. And so with these terms for menstrual disorders, I just need you to know the term, the definition, and just a few causes. I'm most likely not going to test you on treatment because the treatment varies. It just depends on what's the cause, okay? So, again, this information is not heavy duty. It really is self-explanatory. Okay, so menstrual disorders. Okay, so we're going to talk about each and every type, or I should say, term of menstrual disorders that can occur. So the first term we have is something called amenorrhea. A meaning absence, amenorrhea for menstruation. And so this is when the menstruation stops. And so that has nothing to do with menopause, but just the absence of menstruation. So the causes here can be hormonal disturbances. And when we say hormonal disturbances, this can be any type of hormone. So, well, I should say any type, but any situation where the reproductive hormones are imbalanced. So whether it's a congenital situation or acquired, or let's say even when a person, like say an acquired situation like birth control pills, sometimes birth control pills, and there's different types that we were talking about in yesterday's class that females don't have a cycle. Okay, like the Depo and some other things, okay. So that actually stops it, so that's that. Stress, we know can do it as well. Okay, so stressed out, that can also give the situation amenorrhea. And cancers. So some cancers can also give an absence of menstruation. So even if it's like an ovarian cancer, you know, a reproductive cancer, we would imagine. But don't forget also pituitary cancers. So if there's a tumor on the pituitary, obviously that's going to offset hormone levels. Okay, so that can definitely also give the situation amenorrhea. Yes?
Can like exercise like?
Yes, I'm actually going to go over that. Yes, so now amenorrhea, oh wait, yes, exercise definitely. So treatment for amenorrhea is aimed at the underlying cause. So if it's stress, you gotta get rid of the stress. If it's a hormonal situation where a person may be lacking a hormone, give them the hormone. If it's a situation where there's a pituitary tumor, remove the tumor. Okay, so it just depends on whatever the cause is. Now the next couple of slides goes into primary and secondary amenorrhea. I'm not going to test you on this in particular because they all kind of have the same causes, okay, some different, some not so different. But I do want to just go over a few that do stand out. So when we talk about primary amenorrhea, it is something that can come from the hypothalamus, and so we have a situation called anorexia nervosa. Okay, anorexia nervosa. This is the mental health disorder. where these patients are not eating. And so this can actually just change what's happening with the nervous system and endocrine and metabolic rate, and cause them to have a decrease in menstruation. Same kind of situation with strenuous exercise. So when a person, and especially this is common sometimes with female athletes, that they do have a diminished cycle or no cycle at all. I remember in college I had a roommate, she exercised a lot, and she told me that she didn't have a menstrual cycle for like 5 years. So what happens is when you have that type of situation, these individuals now kind of offset the way the nervous system responds to releasing those hormones. And so when the nervous system is now offset to where it's not releasing those hormones, they will not start a menstruation. Okay, so that's what happens.
It's good to be in shape, but is that bad?
It is bad. It is bad. Because if you're not shedding the lining of the uterus, what's happening, it can become thick. And so as we were talking about earlier about how the zygote has to implant onto the wall, it won't attach if the uterus is not healthy enough. And so that long term could possibly lead to an unhealthy uterus. Yes?
How does that play with the fact of like an IUD?
Okay, so, and I was having this discussion yesterday with everyone. The situation with those types of birth controls, the way it's explained to me is that because when you're on birth control, your body's tricked into thinking that it's pregnant. So you don't really produce the hormones that you would be producing when you're going to have a menstrual cycle. So if you're not producing those hormones, it doesn't build up the extra layer. The layer is supposed to stay the way it is. However, I personally still don't think it's healthy not to have a menstruation regardless of whatever you're on. But in this situation, with the strenuous exercise, it's definitely bad because the body's, it is going into a situation where can possibly damage the endometrial lining. The longer and longer they go like that. Because understand this. You know the reason why menstruation exists? To have a baby. That's the only reason why menstruation exists. The only reason why menstruation exists, every month your body has to release that layer of the uterus to shed, to have the uterus lining, the endometrial lining, healthy, just in case you get pregnant that month. So the zygote can attach. If you don't have that shedding, it is a possibility that the endometrial lining may not be as healthy. Okay, not to say that everyone's going to go through their fertility issues, but it can possibly lead to that. Okay, so that's the issue. Okay, now okay, strenuous exercise, yes. I don't want to go over each and every one of these. The gonadotropin releasing hormone, that means obviously the gonads, okay, there is a gonadotropin releasing hormone that comes from the brain, okay, that helps support the gonads. Congenital defects and tumor, yes, okay. I'm going to have you start crossing some of this out because I really don't want to go over each and everything, but just understand we know that tumors can cause an amenorrhea. We know that there can be hormonal changes, okay, no matter what it is, okay, that can cause these types of changes. So you can cross out 5, 6, 7, and 8 times here.
8, 7, 2?
Yeah. 7 through 9. I should have took it. Oh wait, insulin. Because to be honest, in GYN, I don't know if they separate it and go into detail like, well, this is a primary amenorrhea and that's a secondary amenorrhea. The main goal is understanding what's causing it and treating what's causing it. So I don't know if they classify it as primary and secondary as much clinically, but you'll find that out later. Okay, so the next topic, metrorrhagia. Okay, metrorrhagia. Yes, we have a whole bunch of terms here. This is bleeding in between menstrual periods, also known as spotting, also commonly known as breakthrough bleeding. Okay, so this is where there's bleeding in between your normal cycle, a spotting. Now, how can this occur? Definitely, there is slight bleeding, believe it or not, that can come from ovulation. So when females ovulate, we know that there are certain secretions that can be developed. However, sometimes those secretions can also have a blood tinge to it because of the endometrial lining just shedding a little bit. Okay, not like a full cycle, but just a little bit. And so keep in mind also that cancers can do it as well. Okay, it can cause bleeding. And estrogen therapy. Okay, definitely. If when females sometimes are on birth control, and if the body's trying to adjust to the hormone levels and things like that. Sometimes they can have bleeding in between. Sometimes they can have no bleeding. Okay, so sometimes it just depends on how the body's adjusting.
What if you have spotting instead of your period? Like not in between normal periods, but it's like.
We're gonna go over. I think that's another term
Oh,
called. But yeah, I think that's another term. There's so many terms. Okay, hypomenorrhea. Hypomenorrhea is a deficiency of amount of menstrual flow. Okay, meaning that there's less flow that's actually leaving the body. What can cause this? Again, hormonal. Like I said, a lot of things are hormonal. So if the hormones are not producing enough shedding of the lining, okay, or if there's a partial obstruction of menstrual flow. So say, for example, if a female has a cervical polyp, okay, that's maybe blocking menstrual blood from escaping. Oligomenorrhea, I think this is the one you're talking about. This is infrequent menstruation. So this is when a female has a cycle 1 month, the next month they don't have anything, the next month after that they don't have anything, and then the following month, here we go, they have a cycle. So this is where the cycles are infrequent, okay?
Kind of like irregular?
Irregular. Or sometimes spotting can also be a part of this too. What can cause this? Again, they do say hormonal issues, okay, so hormone. Usually things like this, and females know this in the class, that most of the times with these menstrual disorders where it's not quote unquote normalized, they will put females on birth control to hopefully get the hormones adjusted. And so again, this is a hormonal situation. And they say causes of failure to ovulate. However, females that have this also have to be careful because they can get pregnant because they don't know. They don't know their cycle. So even though they're saying here that they're failing to ovulate, that is not quite always the case. Sometimes females are still ovulating even though they don't actually have a full shed. So that's a little tricky. Menorrhagia. This is an increase in the amount of duration of blood. So this is a bleeding, this is excess bleeding. This is a situation that is actually common with reproductive disorders like, say, endometriosis, fibroids, okay, things like that, where there's excess tissue, okay, they can also have excess bleeding. Now, this particular term, dysfunctional uterine bleeding, okay, they put this in a class all by itself, okay, and the reason why this has nothing to do with bleeding from a hormonal thing or birth control or anything like that. But they do believe that this is where, under 2 circumstances. You know how sometimes females, when they start off their menses, it's like bad, and they're just bad the whole time. So they do believe that those females fall under this category. And also the females, or I should say, when females do go through menopause and have the irregular cycles, they put that under this category too, as a dysfunctional bleeding. Okay. So, when females start off during those years, okay, of starting their menses, and it's just kind of bad, okay, bad meaning that they're more symptomatic with their menstrual cycle. Okay, so there's more cramping, heavy bleeding, those types of issues. They do believe it's from an immaturity of the pituitary and the ovary, causing this sort of alteration in their cycle. Perimenopause, we already discussed that, so we already know what happens with perimenopause. Okay. And the treatment for this, depending on what the issue is, maybe surgery if there's some sort of tumor. If not, give them oral contraceptives. Birth control pills are usually one of the most commonly used things. Oh, and antiprostaglandins, I forgot to tell you that. Antiprostaglandins actually help, believe it or not, with menstrual cramps. They help with menstrual cramps. They actually decrease the uterine contraction. Antiprostaglandins. So, which brings us to the next one. Dysmenorrhea. Tired of hearing these terms. Dysmenorrhea is painful menstruation. Well, I know this sounds like an oxymoron. Yes, it's painful. You all know that. However, this is a situation where we're talking about painful menstruation, extreme pain to the point that these females cannot go to work, cannot go to school, very debilitating type of pain from menstrual cramping. And so what really causes this pain, okay, and going back to here they have the primary, develops 1 to 2 years after menarche. So what happens, these patients, these are the ones that start off with those kind of bad cycles. They kind of start off that way. The situation here is that these patients actually produce too many prostaglandins. They produce too many prostaglandins in their bodies. And the prostaglandins is what actually causes the uterus to contract constantly, okay, during that stage and really giving them those severe cramps. Enough to limit activity, nausea, vomiting, everything. I had a girlfriend that suffered from this really bad. Her cramps were so bad she would faint. That's how bad and extreme the pain was. Okay, you've heard of that? Yes, it's really bad. So this is an extreme situation, not just your normal cramping. Now, yes, it definitely affects the quality of life. They can treat it, however, because they give them, prostaglandin inhibitors to kind of calm down those contractions. But they really have to know their cycle, kind of pre-treat it when it's about to hit, okay, so they can try to calm down some of those episodes if they can. Now, secondary, sometimes the bad menstrual cramping and all that can also come from sometimes secondary to endometriosis. So certain types of reproductive issues can also cause this issue with the painful menstruation. Treatment, prostaglandins inhibitors, birth control pills, always given out sometimes for this. And surgical procedures if they have to remove some of the adhesions from like endometriosis. Sometimes the uterine wall gets really thick and that causes a lot of problems too, and so they'll try to remove some of the tissues. Okay. So, now, we have to go over uterine and pelvic disorders. We do have quite a bit of physical things that can occur, and believe it or not, these are actually very common, more common than you think it is. So brace yourself. Yes, I will show you some graphic pictures. So what's going to happen, we have to go over all of the uterine types of displacements. Okay. So the first one we have here is something called uterine prolapse. So this is where the uterus actually will sink and prolapse down into the vagina. And so this is how it occurs. From anatomy, what holds the uterus in place? No, not ligaments. Ligaments. So understand that there's a number of uterine ligaments that kind of hold it, almost look like sort of in midair, but not really, but just kind of hold it in that pelvic cavity. So the situation is this. Those ligaments, believe it or not, can stretch and the uterus can drop. Now, what do you think would make those ligaments stretch? Childbirth, and that goes along with that, pregnancy. So let's think of, what's the show, 19 and Counting? And, well, they have a couple of shows, 19 and Counting, and K+8, and Octomom, and all that, okay. So all those things, keep in mind, multiple births, multiple pregnancies, okay, things like that. Keep in mind, we'll put back and forth, stretching out those ligaments. Those ligaments, unfortunately, do not snap back like a rubber band, which means that the uterus will actually now change into position and fall. What else do you think could cause it to stretch out? Aging, very good. Keep in mind, as we age, just like everything else goes south, unfortunately, those ligaments will also start to stretch, which will cause a drop. So, it can occur at any age. However, congenital defects, they have it listed here, but more common that you see this with multiple pregnancies, multiple childbirths, and aging. That's where you see most of it. When I was in undergrad, I used to work at a GYN office to answer the phones and things like that. And so we would get a lot of the old ladies that would call and say, I see something hanging out. And we would tell them, just come on in the office, because we knew what was going on. So keep in mind, it's very high in the elderly community also that you see this. Anyone works in the field who's seen this? Yes, you've seen it. Was the person older or younger? Older, yeah. It's very common in elderly patients. Okay. So here's a picture of it. Now, remember that sometimes the GYN doctors will say uterus, cervix, and vagina almost like it's 3 separate organs, which we know it's not. So what you're seeing here is actually the complete uterus, and the bottom part here is the cervix. So this is actually a complete full prolapse. Okay. Now this is a severe, this is like a 3rd degree. There's different degrees which we'll go over. But understand that when it gets to this point, obviously very painful, a lot of issues that are occurring. One student a couple of terms, was it last term or the term before, she told me a crazy story about her aunt having this. And her aunt would lay on her back and put her legs up and pop it back in. And I was like, okay, when it gets to that point, you need to go to the doctor. So, sometimes people walk around with this, believe it or not. But in an elderly patient, they, may not be able to do anything about it, if they're in a nursing home or something like that. But when people, sometimes people don't, well, we all know, and you'll encounter patients, and we know that sometimes people that have something, they know it needs to be fixed, but just the fear of having a surgery or whatever the fear is, they don't want to deal with it, and they rather just. Okay.
I mean, that doesn't just automatically happen.
No.
Right? Like it's a like it drops
Exactly.
lower and lower, so it's not like
Right.
so it comes out.
Exactly. So it goes through degrees. I'm going to go over the different degrees now. Now, how fast can it accomplish? It all depends. So say, for example, if you have a person, I'm just using Octomom as an example. Okay, when you have a situation like that, is it a possibility she can be at high risk to have this occur right away? Yes. Okay, yes. So individuals like that. So let's go over the different degrees. So the first degree is where the uterus is halfway between the vaginal introitus and the level of the ischial spines, meaning that it's right at the top, okay, of the vaginal canal. The second degree is where now the cervix begins to protrude through the introitus, which means that the cervix now can possibly be visible, maybe by the patient or definitely on inspection. Okay? And then the third degree is what we saw in the picture before. That's a complete prolapse, okay, of the uterus along with the cervix. So these are the pictures here of the different degrees. So even here, patients will feel some sort of discomfort. Okay, so I don't want you to think they won't know what's going on. They're definitely going to feel some sort of discomfort or pressure. And obviously as it progressed to that, it will be more discomfort. Make sure that you know the description of each one, just in case if I test you on it. I will save you from the pictures. We don't have to get that graphic. But just make sure you know the description.
But you won't have like those pictures up, right? Like
No, I'm not gonna
okay.
put pictures of this one. However, no, not for next week's test. Maybe for this one, not for next week's test. Okay. Now, signs and symptoms, again, depends on the type, degree that they have. Sensation of fullness, vaginal discomfort, discomfort walking and sitting, difficulty urinating, obviously. Because keep in mind, if the uterus is protruding through the vagina, it's actually pressing up against the urethra, okay, and most likely the bladder as well. And bleeding, ulceration in cervix, ulceration from the friction of the cervix. So when they have that complete prolapse, understand that because of friction that can lead to, again, that's why I can't understand how anybody would walk around like that. However, people here. Now, treatment. Treatment for this, they have hysterectomy, obviously, for those full, complete prolapse. So let's say if we have a patient that's 70 years old, okay, and they have this going on, and they have a complete prolapse, and they're trying to treat it with the pessary, but it's still not helping. It's okay, probably that patient would have a hysterectomy because they're not trying to have any more children. It's at a point where the uterus is not going to be able to go back in this position where it was. So they will probably have a hysterectomy. Now, for the first and second degree, most of the times they treat this with a pessary. The pessary just looks like a cervical cap, and they'll fit the patients for this, and they'll just kind of there to hold it in. And from my understanding, I think these patients have to get fitted or resized every year or two for this, if I'm not mistaken, once they have this pessary. In the there's no particular surgery to bring those ligaments back, so they just have to, unfortunately, like hold it in. Okay. So another one that we have is called retrodisplacement of the uterus. This one is a situation. Oh, it's cold. Yeah. Oh, the thing's right here. So this particular one is where the uterus changes in position. Okay. This one is also very common. Okay, and I'll give you an example. Women sometimes go to the GYN, have their examination done, and the doctor says, "Oh, did you know you have a retroverted uterus, or it's tilted and so forth?" And the female says, "Oh, I didn't even know." Okay. And most of the times females don't know. It's just a mild displacement, usually doesn't cause any signs or symptoms unless it's, some other complication occurs with it. But it is quite common. They say that this can develop throughout the woman's life for childbirth and things like that. But this is also congenital sometimes. Okay, they don't have it listed here, but it can also be congenital. So causes congenital pregnancy and childbirth. And there are 5 positions which I'm going to go over now. Oh, not now. I keep thinking it's the next slide. Okay. So signs and symptoms, again, usually no sign or symptom. Usually females don't even know they have it. If it's complicated, in very few cases are complicated. If it's complicated, they'll have pain, dysmenorrhea. Dyspareunia, this is a term for painful sexual intercourse. So sexual intercourse can be painful for those that are complicated, not every case. In the treatment, usually when the doctors say, okay, well you have a tilted uterus or whatever, they usually don't do anything about it, okay, because it doesn't require any type of treatment unless the person's having a lot of pain, a lot of other issues. Then they can use a pessary or maybe surgery if they need to. So let's go over the positions. I don't have normal here. However, I think we know from anatomy that the uterus normally lies almost like at a 90-degree angle, so to speak, to the vagina. Which I always say this, it makes no sense why women lay on their back to deliver babies. Because you actually have gravity working against you. It's easier, nice for everyone else, for the medical team, but you're okay, pushing it for however long, okay, to try to get this fetus out. Has anyone ever seen a birth in a birthing chair, a natural birth? Okay, how long was it? 1, 2, 3, the baby was out, okay? Because if you're in a position where you're on a chair or you're squatting, okay, you have gravity that's actually working with you. This gravity is working against you, so it actually makes the whole labor process longer, the delivery process longer. I don't know, because I know they have a certain way of doing things in this hospital. But birthing centers, they have, different. Yeah, the birthing chair is high. It looks like a real high chair.
Oh.
It's kind of weird looking.
Yes.
Yes, you do have to catch the baby. Yes, yes, it is kind of like that. So, but in any case, it makes sense. Okay. Now, what happens here with this particular position, normal, mid position is when the uterus is slightly tilted to the anterior, just slightly. Okay, so it's not a big tilt, just slightly to the anterior. Anteverted is when the uterus is actually the entire body, the whole uterus is tilted all the way toward the bladder and kind of real close to it, pushing on the bladder. And we would imagine if a female was pregnant with that type, it would have a lot of issues, okay, with pressure on the bladder. So this one is very close to the bladder. Antiflex is also very close to the bladder, but it's actually just the top portion of the uterus where it's flexed. Okay, so this is a flexion of it. Again, maybe with fetal growth it might stretch out differently, but that's how it's flexed. And then retroflex is when the uterus top portion is flexed over to the rectum. And then this one is when the entire body of the uterus is flexed all the way over to the rectum.
Retroflex is tilted towards the rectum.
Yes, just the top part of the uterus tilted towards the rectum. And retroverted is the entire uterus over the rectum.
We have to know this for the quiz.
Yes, know this for next week. It is a possibility. I didn't give you guys the image sheet today, but these pictures are in your book. So it is a possibility I may have one of these pictures for next week's test. Okay, they're easy enough to memorize. And they're in your book. Okay, so more protrusions. Cystal seal and rectal seal. So believe it or not, there is a situation where the urinary bladder can actually protrude through the vagina. And then the rectum can protrude through the vagina. Now, let me go over mechanically how this happens. Okay, so I don't want you to think the bladder just coming straight through, or the rectum. It's more like a herniation, okay, but they call it a cystal seal. So it's a protrusion of the portion of the urinary bladder in the weakening part of the anterior part of the vagina. So let me go back to this picture to show you. So you see right here where we have the bladder, and then this part is the top part of the vagina. So right in this region here, we know that we have fascia and little ligaments, maybe muscles and so forth. What happens here is that this area gets weakened. And so the bladder is actually going to drop right at the anterior part of the vagina, right at the top part. And it's more like a herniation. They don't call it a herniation, but it really is. So it's not that it's a hole going straight through. It's actually just bulging. It's more of a bulge when you see it. Causes, childbirth again, okay, aging, obesity, heavy lifting. So this is the issue. Even pregnancy, and let's go back to Octomom again. I won't use her as an example. But Octomom, obesity. So anytime a person has a lot of abdominal weight, that's putting a lot of pressure on the pelvic floor muscles. Okay, so making sure, I should say, actually making it very weak. So symptoms, depends on the severity. So not every case is severe. Sometimes people have a cystal seal with no signs or symptoms. It's just there. Usually if it's not symptomatic, they don't touch it. Okay, unless it's really causing a lot of urinary issues. So vaginal pressure, fullness, dysuria, back pain. So how they treat this, we have all heard of the lovely commercials about the recall for the vaginal mesh. this is how they treat this with the mesh. So right where the bladder, so this area here, the mesh gets inserted, okay, in the vagina to actually hold it up. Okay, so just like how you would treat any other herniation, umbilical, inguinal, so they put the mesh to kind of hold and support the structures. And so, unfortunately, there is a because the mesh, whatever the material, it's actually causing infections and things like that, or whatever the case is, okay? I don't know what we're doing about that, but in any event, that's what they use to treat it, okay? Another thing I want to point out, the GYNs are the ones that find this from examination, but they have to refer these patients to a urologist. The urologist is the one that actually takes care of this because it's a urology issue. Now, they may have some gynecology, urology specialists. However, it's more of a urology issue than a gynecological issue. And, oh, another question. I have a question to you guys. What do you think is a good maybe treatment or thing a patient can do if they have a cystocele that's very mild or not that progressive? Kegels, very good. Kegels, what they do, they actually strengthen the floor of the pelvic muscles, and they're actually really good, and it'll be good for a situation like this to actually make those pelvic muscles stronger and possibly prevent it from further protrusion. Okay, and so that would be very good for those patients to do. They don't have it listed here, but it would be a good treatment. Okay, that's what it looks like. So this is the opening of the vagina, and what you will see is a bulge coming from the top part, okay, of the vagina. So that's where the bladder is located or coming from, and so that's the cystocele. We can have the opposite situation of the rectum. So the rectum can protrude. So the rectum actually protrudes through the posterior part of the vagina. So it's the opposite end. Causes, again, childbirth. Weakness with aging. The GYN office I used to work at, the doctors, they would definitely check a lot of the geriatric patients for this. Okay, because for some reason, geriatric women actually have this one more than the cystocele. Okay, so they'll have the prolapse and the rectal seal more commonly than the cystocele. Okay, so symptoms again depends on the severity, constipation if it gets that bad, painful bowel movement, and painful intercourse. Intercourse is painful because the penis inserts more the posterior part of the vagina than the anterior. Although I would imagine intercourse would be painful either way. However, it's more painful with this one. Treatment, surgery, okay, again, it has to go to the specialist. So for this one, it would be the colon specialist. And that's that. For that one. And that's what it looks like.
Is that possible too, like when they give birth and like the baby tears, obviously,
Yeah.
is that more?
Yes, that's why they say injury during childbirth. So when the tearing happens from childbirth, it is a possibility this can occur.
Oh,
Or it can occur from the tearing, not only just the tearing, but also the process of the pushing,
oh.
you know, from the delivery, Okay, so this next one, you guys know. PID, you've heard of this before. So just a couple of things I want to go over. PID, pelvic inflammatory disease. We know that this is an inflammatory, this is inflammation of any pelvic organ, okay, of the reproductive organ. So they give you a whole list here. It could be the cervix, it could be the uterus, the oviducts, doesn't matter. It just depends on where that inflammation is going to go. Most of the times we know and always associate PID with an STD because that's usually the most common cause of PID. So the most common causes are going to be gonorrhea and chlamydia, which I believe we know that already. However, PID is not the only cause STDs are not the only cause of PID. Okay, although they're classified that way, and they classify it as an STD because that's usually most cases. However, it is just an inflammatory disease, so it's not always STD related. So let's go over some other things that can cause this. Okay, so number one, pelvic surgery. So say for example, we have that patient that had the cystocele and they had the transvaginal mesh inserted, and now from the transvaginal mesh, the body's rejecting the mesh, okay, and undergoing this whole inflammatory infection process. That patient will start to undergo a PID. The pelvic organs will get inflamed, okay? Has nothing to do with an STD, but it has to do with the complication of that surgery. Insertion of an intrauterine device, IUD. Okay, now, IUDs, they have perfected it nowadays, but years ago, when the IUD first was developed, it was a hot mess, okay? The IUDs were actually contributing to a large number of cases of PID, more so than STDs, okay, because the intrauterine device was inserted and the patient's bodies were reacting to it. There has even been cases where patients have a lot of fibrosis in the uterus from the IUD and it being lodged in and hard to remove. So a lot of bad cases with the IUD. But however, now they've gotten better with it. But patients can sometimes have an infection or inflammation from the insertion procedure of it. And then also abortion procedures. Abortion procedures, just like any other surgery, can have a risk of actual infection or inflammation. So especially with this procedure where we have what is called dilation and curettage, when the curettage is performed, the scraping, so to speak, in the uterus, this can actually cause a possible infection or inflammation to occur. Okay. So that's definitely one part. And then infection during and after pregnancy. Signs and symptoms, patients can have abdominal tenderness, obviously pain in that region, fever, elevated white blood cells, so anything that goes with an itis. Now treatment. Treatment, I think we all know that they have to treat this very aggressively, early aggressive antibiotic therapy. Why do they have to treat this so aggressively? Inflammation that can possibly lead to sterility. Okay, so this is how it goes. When these patients have this inflammation, if this inflammation continues and goes on too long, this can lead to fibrosis. Fibrosis, we know, in any tissue is irreversible. So if these patients have fibrosis, let's say in an oviduct, that's not a good thing. Okay, what's going to happen is that's actually going to lead to sterility. Okay, so just keep that in mind. This is why we have to treat this aggressively, pronto. We don't want to wait because they have a very high risk of becoming sterile. Okay. And so this is what happens here. Okay, so that's just a picture showing you. So, are you guys okay? Okay. This chapter is long, I'm just making sure. Okay, we have to cover some more itises. Okay. Vulvovaginitis, and I'm quite sure we have heard of this, and this is actually very common. Sometimes you'll hear it as vulvovaginitis or vaginitis or BV, bacterial vaginitis. Okay, so they have a number of names for calling this. It all depends on what's the actual cause or what it's actually affecting. So, inflammation of the vulva in the vagina. Okay, so that's what it's affecting. The common organisms are listed here, so please make sure you know number one, Candida albicans, which is the common cause, which is also commonly known as yeast infection. Okay, also commonly known as yeast infection. So there are some others, trichomonas, Haemophilus, gonorrhea, HPV, and herpes type 2. Okay, so those are some others that can also cause this type of itis. No, you don't have to memorize all. No, just make sure you know Candida albicans is the most common type. Okay. However, these are also some others which I'm sure you guys went over in my room. So we'll see that later. So if a person doesn't have an organism that's, causing this infection, sometimes it can be some things that they're using, okay? So, chemical irritation from feminine products like tampons, okay, can definitely cause sometimes that type of irritation. Trauma to the area, allergic reactions, and under this could be dyes from clothing, detergents, even, believe it or not, latex condoms. Sometimes females are allergic to latex, and latex condoms can definitely cause vulvovaginitis. It'll cause that irritation. And antibiotic therapy, and I think we all know with antibiotics what happens with that. So it kills the normal flora, therefore leading to this whole Candida albicans possibly develop. Okay, so when they are experiencing this, they can have a thick white discharge, sometimes red tinge depending on the type. It can be itchy, and so this is an infection, so the infection in that area. Treatment, you're going to treat it by the cause. So if it's a virus, antiviral. If it's a fungal, antifungal. Okay, so whatever is the issue, that's how you treat it. The next one we have here is bartholoiditis. I don't know how common this. I know vulvovaginitis is more common, but this one is, I think, also quite common. This is inflammation of the Bartholomew glands. These glands are located inside the vagina, and they actually secrete a lubrication for the vagina as well as also for sexual intercourse. So what happens here is sometimes these patients can also get a bacterial infection there, and these glands will actually get swollen, okay, and they'll get filled with pus and cause a lot of pain and things like that. So that's that situation. And so how do you treat this? Give them antibiotics, okay, because it's a bacterial infection. And if it's that bad, they say they can drain it if the glands are that large. So, the next one we have, oh, I forgot to bring this picture.
No, I meant like this one. You know what I mean? These are kids.
Okay, I'm sorry, I'm trying to, fine, I have show and tell, I'm trying to find a picture for you.
What?
So, benign tumors. So, this type of tumor is actually quite common. It's called uterine leiomyomas, also known as myomas or fibroids. These tumors, I do want you to know, are actually benign. So they're never usually malignant. Okay, so know that these are benign tumors. Quite common. Okay. She's okay? She's not feeling well?
Does anyone have extra water bottle?
Yeah, that,
Oh.
can you, okay, so we are returning. Just had a little situation, so the classroom is cleared out, so it's just me now. So just to finish up the last few slides, we're going to cover uterine leiomyomas. We're also going to cover ovarian cysts and endometriosis. So for uterine leiomyomas, just know that they're also called myomas, or also known as fibroids. One thing I do want you guys to know is that these are benign tumors. One thing that I was gonna show the class, a surgical picture of my girlfriend, she did have uterine tumors. And when you look at these tumors, they actually are very round, circular type tumors, which really give you that description of a benign tumor, which is well-defined, very distinct looking type tumors. So they do fall under the categories and characteristics of a benign tumor. Leiomyomas are also very common in African American women. And another thing I want you guys to just kind of focus on too is actually what causes these tumors to actually develop and grow. And it is definitely high estrogen levels and growth hormone levels. So which means that usually when females do have their menstrual cycle, so every menstrual cycle that they do have, with the fibroids, it actually kind of feeds on the fibroid and makes the fibroid grow. So this is a picture here just showing you some of the descriptions again of how they actually are sort of very round, circular type fibroids. Sometimes the ones that are embedded very deep into the myometrium are not very good for the surgeons to remove. However, the ones that are closer to the endometrium are easily to be removed. Signs and symptoms, when they are large, sometimes they can cause a very, very severe amount of pain, pressure, backache, constipation, and urinary frequency and urgency, okay? Because keep in mind that these tumors are making the uterus larger. Sometimes patients can have very large abdominal cavity as well, depending on how many tumors they have inside the uterus. So the patients can sometimes look as if they're pregnant. And also they are pressing on other organs that are surrounding, such as the bladder and the GI system. So depending on the size, okay, depends on the treatment. So sometimes the smaller ones, they may not do as much treatment for it and just kind of watch and wait and just monitor it. However, the ones that are actually very large do have to require surgical removal as well as possible hysterectomy depending on how severe it is. So the next topic we have are ovarian cysts. So with ovarian cysts, I just want to cover really quickly. There are 3 types of ovarian cysts that can actually develop. So what happens with ovarian cysts is this. You can have one type, first before I go into the different types of ovarian cysts, one thing I do want you guys to know is that ovarian cysts are actually, can occur in women that are what we call childbearing ages. So women that are in childbearing ages, meaning any women that is having a menstrual cycle, they are definitely at risk for ovarian cysts. Ovarian cysts we know are actually quite common. This is where the ovary will actually start to develop a cyst formation inside of it. Most of the times ovarian cysts go uncomplicated, not much of an issue. Sometimes maybe mild pain here and there, but however, really not a major issue until it actually ruptures. So the first type we want to cover is follicular. So the follicular type of ovarian cyst is this. So we know how during ovulation we have the egg that actually goes through the maturation process. Once it becomes mature and it's time for the egg to be released, that is the ovulation process that occurs. So we know that the end result of ovulation is the releasing of the egg from the ovary. And this situation when we have a follicular type of ovarian cyst, the egg is not released during ovulation and therefore the egg stays inside the ovary and therefore actually develops into a cyst formation. Okay, so that's that particular type. Now the next type that we have, so the maturing ovarian follicle fails to release an ovum. Instead, the follicle continues to enlarge and forms a cyst-like formation and produces actually estrogen. Now the next type that we want to cover is the corpus luteum type. So the corpus luteum type is this. This is where the ovum actually will go through the maturation process, okay, as we talked about before. However, this one is a little different because the egg is actually released out of the ovary. The problem lies with this. Once the egg is released, you know how we have the corpus luteum, okay, that covers the egg, almost like a shell. That corpus luteum Normally in a female that's not pregnant that month, the corpus luteum will dry up and disintegrate. If a female is pregnant, the corpus luteum stays. Well, this is a situation where the egg is released, the female is not pregnant that month, and the corpus luteum stays inside the ovary where it's supposed to be dried up. So when it stays inside the ovary, it actually will now turn into a cyst-like formation. And so that's that particular type, and it will actually continue to grow and now produce progesterone. And the very last type that we have is the fecal lutein type, and this is where we have the egg going into the maturation process. And through the maturation process, as different linings shed and things start to develop, there can be actually fluid that can be secreted during this process. Well, this fluid can circulate amongst the ovary. However, this fluid can also accumulate and form what we call a cyst-like formation, also known as the fecal lutein type of cyst. So, it could be any three of those that can develop. So the signs and symptoms, again, usually when females have ovarian cysts, usually not a big to-do, not a problem. However, these cysts sometimes can rupture, and when they do rupture, this is an immediate situation, emergency situation that needs to be taken care of, because not only the risk of hemorrhaging that can occur, but also the risk of infection. And when a female has an ovarian cyst rupture, it is very, very painful. One thing you don't want to happen is the risk of infection to develop that can lead into a peritonitis, that can lead into a sepsis, and so forth. So usually when that occurs, they will do surgical treatment to take care of that. And our very last topic that we're going to cover is endometriosis. Just a few things I'm going to point out with endometriosis, just to kind of sum up and finish up this video. With endometriosis, they give you the age there, somewhere between 30 to 40 years of age. Just to make this a little quick to understand, endometriosis is when we have a thickening of the endometrium, so the thickening of the endometrial layer. Now this thickening, believe it or not, can only not just occur in the uterus, but it can also occur in other organs, okay, other reproductive organs. So when we have this thickening of, let's say, the reproductive organs or this layer, understand that this can now cause a lot of issues where it can cause irritation, it can cause bleeding, and cause a lot of issue with the patient's reproductive organs, which can obviously in turn lead to infertility. So they have a couple of theories as to how this thickening happens or how it develops. So one theory is thought to believe that menstrual blood can actually reflux back into the uterus, and when that menstrual blood is there, it can actually cause obviously more thickening. Another theory is metaplasia. They do believe that the cells can actually change into a different type, and now causing obviously a thickening of the region. And the last theory is induction. They believe it's a combination of reflux of menstrual blood in combination with, or in conjunction with metaplasia. So here are the sites. Again, as I said to you before, usually the uterus or endometrium is usually the most common spot. However, it can also attack other reproductive organs like the oviducts, the ovary, and ligaments. So just keep that in mind. Signs and symptoms, these patients will have dysmenorrhea. Obviously, as I told you before, they'll have difficulty with menstruation, heavy bleeding, lower back pain, and I explained the whole thing with lower back pain before. Pain, I kind of want you to omit this section where it says pain lasts 5 to 7 days or whatever, or begins 5 to 7, lasts 2 to 3. That's not important to know, because please understand that each case is different. Dyspareunia, this is actually going to be difficulty in painful sexual intercourse, which we talked about before. And they can have pain with defecation and also excessive menstrual bleeding, as we talked about earlier. So treatment. Treatment for endometriosis usually depends on the severity of it. So sometimes patients can have endometriosis and the severity is not that detailed or not that strong to where they may need surgery, maybe just some hormonal type therapy treatments to calm down the proliferation of the tissue. However, sometimes patients do need to actually have surgically remove some of the tissue out of the organs, or, in a case that a personal case that I know of where a person had endometriosis really, really bad, to the fact that they actually had to have a complete hysterectomy. So it just depends on which type, or I should say which type, but how aggressive it can get. Okay, and I think this was the last slide that you guys had in your PowerPoint, so good to go.